This is a case of gastric emphysema occurring in the setting of malignant catatonia. Gas in the wall of the GI tract can present anywhere, least commonly occurring in the stomach wall. Rapid determination of the etiology is necessary to differentiate gastric emphysema from the similarly appearing emphysematous gastritis. Our patient was a 45-year-old white male with a history of bipolar disorder, presenting from the Cook County Jail in a catatonic state of unknown duration. At admission, his vital signs were within normal limits, and a physical exam revealed a catatonic male who appeared to be clinically hypovolemic. Laboratory evaluation of the ED revealed severe hypernatremia, and the patient was admitted to the inpatient medicine service for further management. During the patient's hospitalization, the hyponatremia resolved after treatment with free water. Psychiatry recommended IV lorazepam and olanzapine for treatment of the patient's catatonia. An abdominal X-ray was obtained for evaluation of suspected abdominal discomfort, which was consistent with a possible bowel obstruction. And on hospital day 5, the patient had yet to improve. His abdomen had become more distended and he became acutely tachycardic, tachypnic, and hypoxic, prompting evaluation for pulmonary embolism with a CT pulmonary angiogram. The images revealed gas in the stomach wall, which was then confirmed on a follow-up CT of the abdomen and pelvis. The patient continued to decline and was eventually transferred to the ICU for further care. General surgery was brought on and recommended conservative management with antibiotics and nasogastric tube decompression, and recommended close monitoring of the patient for improvement or clinical worsening. The patient's gastric emphysema ultimately improved over the next several days, but despite this, the patient's respiratory status failed to improve and he remained intubated in the ICU. Moving to our discussion, it's important to note that the presence of gas in the wall of the GI tract is commonly attributed to mechanical injury or gas-forming bacteria, and only 10% of the time does this occur in the stomach wall. Multiple etiologies may have been responsible for our patient's findings of gas in the stomach wall, such as increased pressure secondary to a bowel obstruction, infiltration of this area by the gas-forming bacteria, and of note, an ileus secondary to olanzapine administration, which has been reported in the literature as a side effect of atypical antipsychotics. Rapidly worsening clinical status or lack of improvement after antibiotics and nasogastric tube decompression of the stomach point into the direction of emphysematous gastritis, and surgical intervention is warranted. And so the take-home points from our case, number 1 is the association of atypical antipsychotics such as olanzapine with decreased colonic motility, decreased bowel motility, and potential for severe outcomes such as air and gas in the wall of the bowel. Number 2, it's essential to obtain a surgical consultation as soon as gas is seen in the bowel wall and imaging, because GE cannot be distinguished from the significantly more dangerous emphysematous gastritis by CT scan alone. And conservative management is warranted initially with close monitoring of the patient due to the potential for rapid and severe decline in clinical status.